Okay, welcome to Early Medical Abortion of Pregnancy, Case Studies and Complexities, an information evening for GPs, nurses and pharmacists. My name's Tilly Marnie. I use she, her pronouns, and I am the coordinator of sexual and reproductive health at Women's Health in the North. I'm joined by my colleague Sarah Lorimer from Gen West, who is the team leader for sexual and reproductive health. We're delighted to welcome you to this webinar and would like to thank you for your attendance. The education and ongoing support for healthcare professionals is an essential step in the improvement of abortion access in Victoria. Recent and ongoing events in the States are a reminder that we cannot take access to reproductive rights for granted. This is an important opportunity to reflect on the access provided to pregnant people in Australia. It's essential that abortion access is timely, affordable, accessible, regardless of location, and that this healthcare is provided by informed, trained health professionals without stigma or judgment. Before we jump into the session, I'd like to recognise that the land on which we work and provide our services always was and always will be Aboriginal land. I'd like to pay our respects to elders past, present, and any future leaders, and extend that acknowledgement to any First Nations people here this evening. We proudly acknowledge the Aboriginal and Torres Strait Islander communities across Melbourne's northwest, their rich cultures, diversity, histories and knowledges, and the deep contribution they make to the life of this region. So this evening, I'll start with some information about what has brought us to deliver this session, as well as providing some information about referral pathways and resources. Then I will invite our colleague Kath Hannon to provide an overview of the Sexual and Reproductive Health Clinical Champion Project from the Royal Women's Hospital. Next, we'll move on to our main presentations with Dr. Linda Rose Chapiyama and Dr. Patty Moore, who will discuss case studies and complexities of early medical abortion. This will be followed by a Q&A discussion section and some evaluation. So just some housekeeping before we jump in. This session is being recorded. Please stay muted unless you have a question. Questions are welcome throughout the presentations. However, there will be a dedicated 30-minute discussion component at the end of the session. Ahead of the discussion component, we would encourage you to consider any case studies in your experience which have been complex or difficult, or any scenarios that could arise that you may have particular questions about. Please ensure that you've joined the session using the name that you've registered with so that the PHN can mark your attendance, as certificates and CPD will not be issued if we can't confirm your attendance. So Gen West and Women's Health in the North are both organisations working towards gender equity in the northwest of Melbourne. A key aspect of our work is promoting sexual and reproductive health. This involves providing health education to communities in the Northwest region and also advocating for sexual and reproductive health and rights. We often work in partnership with other women's health services across the state and with partners from community health, local government and health services. So despite the legal status of abortion in Victoria, there remains limited access to early medical abortion. In partnership with the Royal Women's Hospital, Northwest Melbourne PHN, we've worked to deliver professional development sessions to health professionals across this region. Together, we formed a regional working group with local GPs, pregnancy counsellors and sexual and reproductive health nurses to develop education sessions that address priorities for early medical abortion. So we delivered an introductory session on early medical abortion last year and intend to further explore the topic tonight, delving into case studies and complexities to demystify early medical abortion. Before we jump into content, we'd just like to highlight some key resources and services available for support. So 1800 My Options is Victoria's reproductive and sexual health website and phone service. The phone line is open from 9 to 5, Monday to Friday, for general public, health professionals, health and community service workers, as well as friends and family seeking information. They provide non-clinical information and information about service pathways. Their website contains evidence-based sexual and reproductive health information, as well as a database of sexual and reproductive health service providers. This is mapped across Victoria, and you can use a filter function for services or location. 1800 My Options also works in health promotion, support and advocacy. And we'd like to mention that they also have launched a new micro-credential online for abortion, contraception and sexual health in supporting client access. This is suitable for any health professional, support worker or student who's interested in learning how to support clients who are seeking abortion, contraception and sexual health information. And this can extend to people working in your clinics, like administration, for example. So to support 1800 My Options, consider SRH service provision to meet the needs of community and your patients. If you're already providing sexual and reproductive health services, you can register with 1800 My Options and receive referrals from them. 1800 My Options can also be a contact point for information about other sexual and reproductive health service providers. And we also encourage you to promote 1800 My Options in your communities and clinics. We'd also like to highlight the importance of wraparound support for any patients seeking abortion or other reproductive health care. An example of this is referring your patients to Melbourne pregnancy counsellors who provide non-directional counselling services. However, it's important to note that not all patients will necessarily want or need counselling services, but that there is support available to them. So many of you will be aware of Health Pathways. However, we are going to speak to this resource just briefly. Health Pathways is an online resource written by GPs for general practice teams. It provides clinicians with locally agreed information to make the best decisions at the point of care. Each pathway is written for use during a consultation with the intent of providing clear and concise guidance for assessing and managing a patient with a particular symptom or condition. Health Pathways includes local referral guidance on when to refer, where to refer, and what to include in your referral. The process of developing content for Health Pathways is a collaborative effort between local GPs, specialists, allied health providers, and other subject matter experts. Each pathway is evidence-informed, but also reflects the local reality. Health Pathways aims to enhance clinical knowledge and promote best practice, to reduce variation in care, to improve the quality of pre-referral workup, and to reduce delays with referrals. It also provides you with information on local services available to your patients. So the next few slides go through the pages specific to early medical abortion on Health Pathways, as well as highlighting other topics that may be related, such as family violence, consent, and mandatory reporting requirements. Here you can see the termination of pregnancy page on Health Pathways and relevant considerations highlighted. You also have the opportunity to send feedback on the pathways if they could be clarified or improved. Here we have the page specific to medical terminations, and we do encourage you to read these in depth following this session. This page provides you with information about referral, depending on the symptoms and circumstances for your patient, as many will require different support. And there are also links to further information for health professionals and for patients to learn more. So to access Health Pathways Melbourne, go to the website address melbourne.healthpathways.org.au. Health Pathways Melbourne is available to general practice teams and other clinicians in the Eastern Melbourne PHN and Northwestern Melbourne PHN catchments. If you don't have access yet, you can click on Register, which brings up an online form. And the PHN can also organise automatic login for you, so you can access Health Pathways without a username and password. So you can just email the team on info@healthpathwaysmelbourne.org.au. And it's now my pleasure to introduce Kath Hannon from the Royal Women's Hospital. Let me just get my screen share back up. And Kath, you can take it away.
Thanks so much, Tilly. I just wanted to take a moment to introduce the Sexual and Reproductive Health Clinical Champion Project, as my first slide will attest. And I'll just go to the second slide, Tilly. And to point out, there are a number of resources that have been developed by the Clinical Champion Project to support community access and knowledge and confidence around providing early medical abortion. And all of these resources are available on the Women's website. I've just listed there the resources around clinical guidelines. There's a web page on early medical abortion. And just in the last 6 months or so, we've released an early medical abortion e-module, which all of those links are available on our website, and we'll send this information after the event tonight. In addition, the Clinical Champion Project support a community of practice forum, which is a forum for all providers of all shapes and colours and styles who are currently providing or think about providing early medical abortion or surgical abortion and contraception care. Again, that link will be on our website. You do need to register for it, and we have a network meeting each quarter. And we, at the Women's, we also provide a monthly session for Implanon next practical training, and we also have an IUD training clinic for providers, either lapsed providers or typically it'd be GPs who've got some level of skill but have lost their current practice and who are wanting to get back into IUD procedures. And that last link there is for the website that I talked about before. And then the next page is that is the web page that I was talking about. And so there's 3 pages within this web page that talk to general information and then specific resources that are appropriate for people who are interested or who are currently providing early medical abortion care. And then the next slide is the cover page for the early medical abortion e-module, and that complements the 1-800 My Options e-module around sexual and reproductive health. But this one goes into, more specifically, goes into early medical abortion. It's all free. You just have to register. It's hosted by Women's Health Victoria, so you just need to register onto their website. And yes, the content is a range, not just the clinical component of providing early medical abortion care, but talks to what the law is in Victoria, what the working with a woman or gender diverse person in a consultation, looking at their options, so thinking about the language you'd use, and then obviously the clinical component. And we're also, in the future, we are in the process of developing a module on the topic that we're talking to tonight in terms of post-procedure care. But that's in its very early stages of development, so we'll let you know when that has progressed. But thanks, Tilly. I'm going to hand it over to Paddy now, Paddy, and to Linda Rose, who will talk to the content of tonight's session.
Thank you very much, Kath. And I guess I just wanted to comment on all of the work that Kath's put into having these readily available and free resources online through our website. That we recently got some statistics on the number of hits that we get in a week. We get 10,000 hits a week to the Women's Hospital website, and 80% of them are around fertility questions and contraception questions. So it's a very well utilised source of information, and is really good for both patients and clinicians. It also has a point of difference, particularly with regard to early medical abortion, that currently the only way that you can train to become a prescriber is that you have to have a medical degree and you have to be registered with APRA, and then you register to train on the MS2 website. And that is actually currently only open to medical practitioners and not to nursing colleagues or social work colleagues or anyone else. So this is a real point of difference that we've tried to address. Having said that, this is something that has been taken to the TGA recently, and that may all be about to change if the application from Mari Stopes International makes it that you don't have to register specially for to become an early medical abortion provider. And there's a great deal of advocacy going on about this. And a lot of you will know that we have there's a Senate inquiry going on at the moment called by the Greens, a national Senate inquiry into equity of provision of sexual and reproductive health services. And this is one of the key advocacy issues, is to acknowledge that early medical abortion medications are safe and are drugs like every other drug and don't need special legislation. And in fact, that the legislation itself is a barrier and a limit against equity. So that's my party political broadcast to begin the post-procedure presentations, because part of what Linda and I did at the previous talk was we really tried to reassure people that early medical abortion is something that is safe to do in primary care. It's supported by gynecologists such as myself, that we think it's safe for primary care to do. Linda is the living embodiment of this. She is a primary care physician, and she works doing telemedicine, providing early medical abortion across the state and sometimes across the country. And we are trying to show that it's possible, that it's not as complex as it would seem, and that it's something that you could consider. Now we're looking at, that was about 10 months ago we did our first talk, and we're really hoping to hear from some of you who became prescribers as a result of that discussion that we had some 10 months ago. This talk is based on the kind of questions we get a lot in our role as being a secondary or tertiary supporter of primary care delivery of early medical abortion. And again, the thrust of the talk is that the common things happen commonly, that they're not necessarily pathological processes, but they're what you would expect when you initiate a process of medical abortion, and that they can be managed, and that there's a systematic way of managing them to decrease the amount of anxiety for both the patients and for the practitioners when they encounter some of these, and also to point at some of the more unusual or potentially really important things that we need to screen for. So could we have the next slide? Can we advance them ourselves?
Can we? No, we can't.
No. So Tilly, if you wouldn't mind doing the honors when I say to advance. So one of the most common things that when I was first doing these traveling road shows, when we went round outer metropolitan Melbourne and then rural Victoria, was to answer the concern about how often do people bleed heavily? How often are our patients going to end up in casualty? What if something goes really badly wrong? And this is to address that with the statistics and to reassure that we now have a lot of data. We have 25 years of international data, and we have the data about the delivery of the service since 2005 here in Australia. So we can be really reassuring. And just to remind everyone that with regard to success rate, 93 to 98% lead to a complete abortion process. So the process is completed. In the remainder, For some of those, curettage might be necessary to evacuate the uterus, but there are other ways to help the uterus evacuate, such as using medical management. This is a real take-home message for everyone, that expectant management of retained products of conception is appropriate for at least up to 2 weeks. And by attentive inaction is the way I would call it. Being there for your patient, being there to reassure them or to talk to them about their assessment, their symptoms, but not necessarily to act with investigations, is in the vast majority of cases appropriate for at least up to 2 weeks. And this is the other point that I would make about the difference between early medical abortion and surgical abortion, is that it's important to emphasize right from the very early discussions with the patient that we're talking about initiating a process rather than performing a procedure. So procedure is like a moment in time. I've been thinking about this a lot because I do both surgical and medical abortions, and that there's something about the theatre procedure. It's a finite moment, and then the procedure is over and the patient leaves the hospital, and the expectation is that they will have very minimal PV loss, for example, or very minimal symptoms. But comparing it to the process of menstrual bleeding is probably more appropriate than calling it a procedure, because most people are aware that a menstrual period is not over in 30 minutes, that it takes 4 to 5 days at the very least for most people. So my clinical point on this page is not to ultrasound everyone who has bleeding greater than 7 days. And before we go on, I wanted to just have a conversation with Linda about this. Linda, do you feel as time has gone on that your practice with regard to who you would scan when they come back with symptoms has changed, or would you have any comment about this?
Yes, so I'd agree, Patty. Thank you for handing over. So when I first started doing medical terminations, thinking back to 2015, 2016, I would probably panic myself, right? And often what happens is the pregnant person, or not pregnant anymore, would come in worried and stressed, and the impulse was to investigate and scan. So I actually routinely tell people that you can bleed for up to 2 weeks, and that's still normal. And then review them still at that week mark if I can. But definitely, I can't remember the last time I ordered an ultrasound for anyone under 2 weeks, to be honest. Definitely not what I do. And we know there'd probably still be products there. So you're already setting yourself up for more panic when there's something reported in the uterus. So definitely, yeah, definitely not under 2 weeks, unless there's other signs and symptoms, obviously, or they're very unwell.
Something, like frank hemorrhage or infection or something else that's going on. But as we've gathered the data from internationally as well as nationally, even in response to the pandemic, we're aware that people haven't been able to access immediate care as often, and that the safety data has been upheld with a lighter touch approach, both to assessment but also to follow up. So that's in itself very interesting. The other thing is, I think it's a natural progression, actually. When medical abortion was introduced into Scotland, when I was first there, the procedure was that the patients were admitted for up to 76 hours. And I was a junior resident then, and one of my jobs was to scan everybody after they'd passed the products, and also to check the products. And the thing that I learned there was that people never really passed the products in a convenient place for me. It was usually in the toilet. And so it wasn't seen by them or us. And the other thing I learned was that the scan always showed a whole lot of blood in the uterus. And those two learnings have been very important going forward. I guess the other thing I would say, Linda, is that there's just this expectation after surgery that it's completely empty, which isn't true at all, because the uterus relaxes a little bit after the initial response to either syntocinon or the doctor rubbing up the uterus at the end of the procedure. but we don't scan them 24 hours later. A rather elegant study did do that to see what was happening, and the majority had some degree of either debris or clot that could not be determined on the ultrasound whether it was retained products or clot. And these are patients that had been deemed to have an empty uterus at the time. But we don't go looking for that with surgical abortion because we're more confident about it. We could have the next slide. I guess one of the other really big take-home messages or slogans about tonight is to manage expectations, and to, in your counselling, always be really realistic about what the process might feel like for the patient so that they are really making an informed decision. I still remember the young patient that I saw once fairly early on when I was doing early medical abortion. I was doing it through a hospital clinic over at the Austin, and the patient was there with her partner, and they said they had done a lot of research online and they were here to have the tablet that absorbed the pregnancy. So that was their understanding from the reading that they had made, that the tablets would somehow absorb the bleeding back into the body. They were very intelligent people. We had a look at the material that they'd read, and it was confusing. It really was euphemistic about how much physically a person would go through during this process. So the other thing is that some of the side effects, some of the feelings they will get are caused by pregnancy as well. So nausea is a really common side effect, and it needs to be addressed so that when we're giving people medication to intercept a pregnancy, that medication can be absorbed. So always thinking about managing nausea first, and and cramping, for example. So if we look at effects of the abortion process itself, cramping and how to describe the menstrual cramps, often described as similar to menstrual cramps, but at a very different extent. So it might be similar in nature, but greater in magnitude. And it's worth assessing the patient really well about how they manage their menstrual flow themselves. How much bleeding do they usually expect or experience rather? What sort of medication do they need to manage menstrual cramping if they get it, and when it starts? It is very varied, the experience, but as a general rule, the bleeding and the pain is somewhat less if it's under 7 weeks as compared to over 7 weeks. So I may make a bit of a difference when I'm discussing that with the patients. Vaginal bleeding, I completely agree with Linda. It's the median bleeding is 9 to 13 days. So I do use the comparison with a period and say that it's longer, and to expect that. It's often described as similar to a heavy period or a spontaneous miscarriage. Now, the majority of women may not have had that you see in the first month or two that you're prescribing, may have had neither of those things. So it's important to find out what their experience has been, and to really choose the patients wisely. If somebody has endometriosis and adenomyosis and requires endone and tramadol to manage their period, they are probably going to find it extremely difficult to get their pain under control during a medical miscarriage. The common side effects are nausea, tic, that can happen by being pregnant as well, and vomiting. Diarrhea is a very well-known side effect of misoprostol and can be very inconvenient when people are bleeding and also have diarrhea. Headache is also not uncommon. Dizziness, possibly from passing clots, but also just feeling dizzy is quite common when you're in the pain of the passage of the products of conception. Misoprostol itself can cause a feeling not dissimilar to a rigor. So fevers and chills and hot flashes and feeling really warm and then cold are not uncommon. So when we talk to patients later, if they're ringing up with those symptoms, it's important to work out temporally where they last took their miso, because they may not be having signs and symptoms of sepsis, which is drummed into us to screen for, but it's probably more likely it's misoprostol. So important that they're aware of those things, and then also really important to prepare the patient for how they're going to manage some of these symptoms. Tilly.
That was a message from Tilly. That's all right.
Oh, yeah. So Tilly's moved it on. Yeah. So patient acceptability approximately 90%. So if we ask patients, the kind of quality studies that have been done internationally usually phrase it around, would you, if you were pregnant again, choose this method, and would you recommend it to a friend? So using those kinds of assessments internationally, no matter where the service is and how it's delivered, whether it's delivered in a clinic or whether it's delivered in the home, it remains at around about 90%. So there's going to be some who really didn't find it gelled with what they had expected, or they had a bad outcome. So on the positive side, people report that they really like choice and they like being involved. And we know that in a lot of quality of life outcomes from lots of medical treatment choices, including surgical options, management of pain, palliation, chemotherapies, that if the patients perceive that they've had a choice in the initiation of their treatment regime, that they feel that they've had more agency and they cope with it better. A lot of people like to avoid anesthesia. They like the privacy of it and they like the convenience. But on the negative, and it really overwhelmingly, the number one is prolonged bleeding is a negative. And people might like to comment on why they think that is, particularly if we prepare people for it. I've often used that it's possibly that it just keeps reminding people that they're still having an abortion, and the difference in that process versus a procedure, that it's gone. I had the abortion yesterday. I'm now having my new life, versus this, and that people are maybe not as prepared for that feeling. And people might have a comment about how they prepare patients for that. I'd love to hear about that. Linda, would you like to comment on that at this point? I know you're going to talk a little bit in the next slide about preparation for success, but anything about how you talk about the impact of bleeding?
I think I just try to normalize it, because I think what I found is that a lot of pregnant people worry that if they're still bleeding, has it not worked yet? Particularly if they've gone early around the 6-week mark and they didn't see much pass other than clots, for example. I found there's a lot of anxiety because they think maybe it hasn't worked, I haven't passed everything, what's going on? So I think that whole time frame is important. If you really stretch it out to that almost 2 weeks, they don't start to panic at day 5 or day 6 or whatever it is. And then give them their options. Sometimes you sort of pop timing of contraception on there, sometimes discussing whether or not we start the pill, you know, at day 7 or between day 7 or 10 or something. If we're confident we've passed it, may then help settle things like that bleeding. If you can see them in clinic or even via telehealth, reassure them that, you know, they have no signs of infection, they're otherwise well, everything else is okay. So I think it's, just about the preparation makes a huge difference. So they know it can happen, and then thinking about how you can intervene. I mean, I've had some patients bleeding for a month. Some of them didn't bother them at all, others getting quite distressed about it. So having an idea when you might step in to help address that, or refer on for DNC or something is important as well, I think.
And we'll probably get to that a little bit more when we do the deep dive into the case histories, yeah? The other things that people talk about typically are the number of visits and, the inconvenience of doctor visits or back to the clinic visits, the uncertainty as to whether the procedure is complete, and also the possible challenges to initiation of contraception around the time of the procedure. We do know that we can institute Implanon on the day of the mifepristone, so that can be done and is quite convenient for quite a few people. As you're saying, Linda, you don't have to wait for a new cycle to begin to start the pill. Quick start as a methodology is really well established for initiation of the pill after miscarriage or abortion. And if we're confident that even though there's still some bleeding, the majority of products are passed, it's safe to initiate the pill, which, as you say, might settle things down. With regard to the number of clinics and the doctor's visits, things have shifted in terms of what we are now aware of from the literature. And the two big studies that are now colloquially referred to as the pandemic studies, one out of the NHS and the BPAS services in Britain, and the other from Planned Parenthood in America, where they pivoted during the pandemic to having very low, very light touch assessments with no testing in some cases, and very light touch follow-ups with prolonging the number of weeks before the patient did a home urinary low sensitivity test, as opposed to coming back to the clinic for a scan by the doctor if it's a clinic that's got scans, or having a repeat beta HCG done by blood. And how reassuring that has been. So even as we're talking here, Linda, I can see that we can possibly maybe push up our acceptability if we can address some of these irritants for our patients. And Tilly, onward. So this is Linda's slide. So again, talking about best to be prepared. So over to you, Linda.
Yeah. So I found in offering medical termination, medical abortion in clinic or online, that a real difference in the level of anxiety of your patients and whether or not they feel reassured is how well you prepare them. So in our initial session last year, we talked a lot about what you as prescribers need to do to have set up to be ready to go. And I just wanted to point out some of these things that often as medical people, we may not think about in much detail. We're focused on the drugs, the doses, the timing, here's your prescription and so on. So location and timing. I found sometimes people are panicking and wanting to get things done quite quickly when they don't want to be pregnant anymore. But I found that talking to my patients and saying that they need to be somewhere where they're safe. So not with an abusive partner, for example, who might question what's going on. If they're possibly younger and don't want to be home with a parent, somewhere they're going to be safe and comfortable. An example I had recently was someone who arranged to take her mifepristone at home, but then did the misoprostol at a friend's house who had actually gone off to work, and she had a bit of privacy to do it by herself and be able to get through the process. It will help your anxiety as well if you reconfirm that they can get to an emergency department, or out of hours care is an option in case something is going wrong at 2 or 3 o'clock in the morning. I just want to shout out there as well, the MS two-step do offer a 24-hour support line. So that out of hours care aspect, particularly for a lot of us GPs who are very sessional, possibly limited sessions, is important. And then the real practical things for your patient. When do you have to be at work? Probably not a good idea to go to work the day after you do your misoprostol, for example. Probably not a good idea to take it at work. That I've had some patients say, no, just, pop the tablets in at work, I'll be fine. And then childcare is really important. In terms of a lot of the pregnant people, I've found a lot of people considering medical termination when they have a baby, right? So a recent pregnancy, perhaps above 12 months or under. And I like to point out to them and say, not a good idea for you to be the only person responsible for a little bub, even a toddler. Get some help, daycare drop off, friend, family, whoever it can be. And then also, if safe, to encourage them to have at least 1 or 2 people they can talk to. Someone who's going to be able to support them, understand what's happened, and understand that there's going to be a bit of emotional ability, that they will be up and down. that those kind of hormone changes and dips are a reality when you're going through this process. And if they go in having thought about all of these things, the actual process just is a lot more streamlined. They're not sort of panicking at work when they're flooding with bleeding. They're not, trying to manage a 2-year-old or something at the same time as well. And then in terms of this as well, I encountered patients where, particularly if they thought, oh, it's just going to be a bit of a period, I'll be fine. I like to really stress that the medication other than the MS2 step drugs is important. So ondansetron, absolute game changer. Misoprostol and the mifepristone as well can really worsen nausea. So someone who's already got severe nausea in pregnancy, encourage them to take it. I offer it 4 milligrams before mifepristone, probably 8 milligrams before the misoprostol. Analgesia, also really, really important. I find I push my analgesia particularly for primips who've never experienced labour, contractions, because they may underestimate it. If someone's given birth a few times, for example, or laboured, they seem to have a more realistic appreciation of what it may feel like. So that range from menstrual cramps all the way to it feels like contractions. Get them to take this medication at least an hour before the misoprostol. Reminding everyone that we know from the literature, particularly with NHS studies, up to 1,600 milligrams of ibuprofen is safe to take as a dose, and that's what I recommend. I usually recommend 800 milligrams an hour before, and I'm very clear. I'm asking you to take double the dose of Nurofen. Yes, I mean double. Yes, I mean 4 tablets, so that they take it. Paracetamol, possibly Panadeine forte with some codeine as well. And then as Patty had also mentioned, if they've got a really significant history of things like endometriosis, for example, with severe pain, you may want to offer some tramadol, possibly some endone, whatever it is you think that is going to be appropriate. So spending a lot of time focusing on that so they understand pain relief and anti-nausea is important. And then I like my non-medication options as well. Heat pack on the back. You often get back pain, movement, talking people through, if you think of possibly early labour things as well from clinics, possibly in the shower, hot water on the back, for example. Give them a few of these options if you can, possibly at the initial consult and when you're prescribing, so that there's less panic when the pain hits and it's all done and you've got a really good plan to go ahead. Tilly? I just wanted to show this again because I showed this in our initial session last year. So this is an example of something that I actually discuss with them, print, give it to them, and then also email to my patients. So there's often a lot of information to take in. So having something written that's on your practice letterhead, online, whatever it is you can find for them to remind them of what they're doing and to keep it as simple as possible. I find I think of 9 and 9. So 9 p.m. on the day, you're going to do your first step. 36 to 48 hours later, you're aiming for another 9 a.m. if you're doing 36 hours later. And you'll notice I'm very particular. And so depending on you've spoken with your patient, you'll have your day and your date. Time's simple. Have something to eat, a bit of a light breakfast, all your pre-meds. You've got 4 tablets from the box. And then just a little bit of those reminders. Bleeding can start quickly. Have a maternity pad on, be ready, and you need to be home, okay? Look, realistically, some people may not be able to do that. They may not have the luxury to do that, but trying to arrange that as much as possible is really important. And that MS2 step line, I've had a lot of patients who say they rang up at 2 or 3 o'clock in the morning when they were vomiting or in pain, and there's really good trained registered nurses who do that line. And then, I always provide a letter in case they need to go to ED, in case they need to see another healthcare provider. So just a really good reminder that a lot of the issues that patients will complain about and they raise down the track, if you have prepared them well with information, verbally, written, and so on, you're going to be able to get ahead of a lot of those issues. Tilly? Now, just in terms of preparation, again, thinking about your patient selection when you're offering this, I just wanted to sort of briefly touch on these before we start going more into the more common known issues. Wanted to point out that we discussed organising an ultrasound for all of your patients prior to prescribing. And these two things I've seen more and more commonly, okay? So I wanted to just say, beware the empty sac. When you have dated a pregnancy and someone should be 7 weeks, 8 weeks pregnant, but your ultrasound says there's an empty sac or no yolk sac, and then also the scar ectopic. So I've had a few reports from ultrasounds where it just says the products of the pregnancy embedded in a previous C-section scar, otherwise all normal. And that can be deceptively reassuring. I wanted to point those two out because those are really high risk in terms of it being ectopic. So if you can see the tissue, but it's embedded in the scar, that has to be managed as an ectopic pregnancy. You cannot prescribe MS2-step in that scenario. And if your sac is empty, again, ectopic until proven otherwise. Have had in reviewing clinics some near misses where you can get by confident prescribing in the community, but I just wanted to hopefully put those in your minds. The empty sac, when it shouldn't be, you're over 6.5 weeks on dates, and any scar ectopics. Please remember to pick up the phone, go online, find your local referral centre and send them in as urgent review for our gynae colleagues as ectopics. And then I wanted to point out briefly, because a few people had asked me prior that there is, as Patty was mentioning, with increasing research and the NHS really pushed by their COVID lockdowns and just needing to get more creative. You may hear the term VMA thrown around, which is very early medical abortion. So these are the things I think are really important if you're choosing to do that. What VMA means essentially is that you are confident on dates, you're happy, you've got accurate dating, but when you do an ultrasound, there may just not be much to see yet. So a person may only be 4 or 5 weeks pregnant at that time, and you haven't got a gestational sac that's convincing on scan. If the patient has not had a previous ectopic, maybe they've had 3, 4, 5 children before, and so not a primip, I suggest, especially for people starting out, not to do this via telehealth. Reason for that is you get to examine your patients. I found that with consent, insertion of a speculum, for example, checking for pain and issues can help reassure you. You can check their blood pressure, get much more of a feel for it. Then with early scheduled follow-up and early repeating of your beta-HCG, it is something you can offer. So you may see that thrown around, and I'd actually recommend for people, once you're starting to get more confident, ETG Online has what I think is actually the best summary of how you may start to consider offering a very early medical abortion. Essentially, you want to try and do beta-HCG as close to the day of mifepristone as possible, and then you repeat it 7 days later. And the takeaway is you want that repeat one to be 20% or less than the initial. And then you can feel quite confident that you've done an appropriate thing. And that early follow-up as well includes really good advice around the signs and symptoms of ectopic. So if you start to think about it, have you got shoulder tip pain? Have you got pain but no PV blood loss, and so on? And with the communities of practice, once you get more confident, a lot of people start offering this very early medical abortion as well. But when you're starting out, quite recommended that you stick to an ultrasound confirmed if you can, as you get more confident with it all. Tilly. All right, back to you, Patty. Oh, you're in silent, Patty. You're muted.
Yes, so Kath and I have been having a nice chat here. I apologise.
Not at all.
I just wanted to thank you for that, going through that so clearly, and also to just really reiterate what you were saying about the possibilities of very early medical abortion, and to just again go back to that history of the introduction of medical abortion and the way it's run by different countries. So I mentioned earlier I was involved in the very early introduction of it in Scotland, and the NHS always delivered it in clinics where they actually had a large mass of patients. That's being now semi-privatized with BPAS, but they use the same model. So they actually have a really good sense of pattern recognition. And the nursing staff who are doing the initial intake and who are assessing the patients have a really good performer that they go through that includes a very detailed assessment of someone's menstrual cycle. And they have to have a really good menstrual history of regular periods to help them establish the gestational age. So it's not just your periods regular, are they? Kind of question. And a really good screening for those who are at risk of ectopic. And then if there's any risk, those patients are scanned. And so it's based on a very, very good, as I say, pattern and an imposed protocol on those patients. But they didn't start doing that, did they, Linda? They didn't start that way. They started by scanning everybody. They had people like me running around admitting patients and scanning them. And after 20 years of doing that, they became more confident. And then the pandemic pushed them. We're talking about if you are the person who's thinking, look, I think I'll try this in my clinic. None of the other doctors are trying it, so I'm just going to be a little bit on my own. But I'll have my community of practice. I'll attend the quarterly meetings that they're running through the network. But I think I'll just stick with the safe stuff and just scan first until I get my confidence up and hear a little bit more about this, the EMA. We don't, you know, and particularly I really feel for some of our rural colleagues who find it extremely difficult to get a reasonably priced ultrasound in their area anywhere within 6 weeks of requesting it. So there are places where they're forced to work in this way. But if you're not feeling confident about it, an ultrasound is a good thing. The only thing I would add about the ultrasound is don't do it too early, because you'll get an empty sac and then you'll have to repeat the scan. And every ultrasound scan comes with the potential of it costing the patient. So just being aware of the timing of that. Let's move on to case histories, because they're always more engaging in some ways. So and again, these are not sort of the weird and wonderful and overly dramatized. These are just the typical kind of questions that come up. So Jenny is a 40-year-old woman. She's gravid of 4, para 3. She's had 3 normal deliveries. She has a regular cycle. She's separated from her children's father and is now in a new relationship. She had her last menstrual period 5 weeks ago, and her periods have had changes over the last 10 years, where the cycle is a little bit shorter than it used to be. She used to have a 28-day cycle. Now it's coming up at about a 23 to 24 week cycle, 24-day cycle, sorry. And so she, by that estimate, reckons her last period was about 5 weeks ago. And so she did a pregnancy test at home and then did another positive pregnancy test in the office. And if we could have the next scan. So there's an actual scan of I took of a person. I have fictionalized Jenny. She's a conglomerate of a whole lot of patients that I've been involved with. But this is to illustrate to you all what a vaginal ultrasound scan would look like with a beta HC of 1900, which would fit with someone who's about 5 weeks pregnant. And the zone of differentiation, meaning when would you expect to see a yolk sac, sits at somewhere between 1,200 and 1,500, depending on the operator and how good the machine is. And machines do vary. But with a beta HCG of 1900 on that day, the day that she had the scan, you would expect that you'd be able to see, you should be able to locate an intrauterine sac if there is one. And you would be hoping that there would be a yolk sac. So Linda was saying, beware the empty sac. I like those kind of homilies where, you know, beware the red eye, the unilateral red eye, beware the empty sac. But this sac isn't empty. And I know we're dealing with shadows here, but that is the yolk sac there. It's tiny structure here. And it's that you can see it that early with a good targeted vaginal ultrasound scan. This is probably the early fetal pole here, by the way. I was involved in a study in New Zealand where we had patients volunteer to supply the products of conception afterwards, so we could analyze them with a view to using visual cues to tell people what to expect. So if we could have the next scan. So this was when I washed, post early medical abortion, I washed the sac that was passed. And this is exactly the same patient with a beta HCG of 1900. And you can see how big it was. So just under 2 centimeters. It doesn't look like this, by the way. This is washed. So that's all the villi that you can see there. Most people would experience that as passing a clot into the toilet. But we had a special sieve technique that we were using on the toilet. You can see where I was working at the time. And on with the next one. So the point I would make just before we go on to that is that, sorry?
No, sorry.
That it makes perfect sense to do these cases early, doesn't it? So if we can target an ultrasound scan and see a really early sac like that and be happy that it's intrauterine, the chances of this being successful are really good for this patient. Now, this is a common question. When can we put in the IUD? And Jenny's really keen to have a long-acting reversible contraception that she can really rely on. So we call her on the day of the procedure. She talks about having heavy PV loss over 2 hours after she's taken the myso. So we call her around lunchtime, going by the 9 a.m. rule that Linda was talking about. So she's taken her myso at 9 a.m. on step 2. She went to the toilet because it was the most comfortable place. She didn't see any products of conception, but the bleeding settled quickly. And what I wanted to emphasize there is it's that history of having quite severe pain, which then settles and gets better, is more significant than definitely having seen a sac. Just a follow-up from that study that we did in Auckland, where we had all these visual cues to show people what to expect. And then we asked them at the end if they thought that this was useful. The overwhelming response was thanks, but no thanks. We'd rather not have the visuals. So that was interesting in itself, that people preferred to have a description rather than seeing the grisly details. She's had light bleeding for 7 days, and now she bleeds if she goes for a run or goes to the gym. She's generally feeling well. If we don't look at her beta HCG first off, is it safe to insert her IUD? Linda, how would you feel about inserting an IUD for her on day 9? So she's been bleeding lightly for 7 days.
Yeah.
And you don't know the beta yet.
Yeah, we don't know it yet. So in that clinically, I would want to do an assessment. So I want to check for any signs of significant pelvic pain first. Want to have a conversation with her. Has she had any fevers or sweats? Is there anything that is concerning to me at the time? And if the bleed has happened and I'm quite happy, I would actually be quite happy to insert an IUD in this patient. Depending on the amount of bleeding though, so when she runs or goes to the gym, it's probably prudent, because I don't have an ultrasound in my clinic. I may want to do a pelvic ultrasound before I insert for her as an option. And I try to do a lot of shared decision making with my patients. So discuss with her that we could go ahead and insert, given we're quite confident it's all worked, or give the option of a pelvic ultrasound prior as well. So that whole with the scan help, I think that I try to ask my patients to get their input around what they're more comfortable with, and inserting in rooms that ultrasound I think would be appropriate.
Good. So I was just going to go a little bit more assertively than that and say that to me, what's significant in her history is that she feels pretty well, and she's actually gone back to running in the gym. And she reports some bleeding after running, not needing to, I should have maybe stipulated that a little bit more. She's not soaking her pads. There's pretty light bleeding for 7 days. And I would be an advocate of not necessarily scanning, because you'll see some debris in the uterus. And what would that tell me? But I would, before I put in an IUD, I would do a quantitative beta HCG if I was doing it at 9 days, say. If I was doing it at 3 weeks, I'd be happy with a low sensitivity urine pregnancy test. But her beta HCG is 169, and then reminding everybody that it was 1,900 8 days ago or 9 days ago. How do people feel now? Would they feel more confident? Linda, would you feel more confident?
I would. We've had a significant, that drop is appropriate. And that's quite interesting in that difference of practice, Patty, because I usually find that number causes a lot of anxiety. So sometimes if I've seen a patient for just the MTOP, they may see another doctor before they come back to me, and they've had the beta HCG test done, you know, at 2 weeks or 3 weeks. And then they're panicking because that's a very clear pregnant result. And so that kind of education around, it's going to take a long time for that to go to zero. We're not looking at the numbers. And as you said, I want to know how you are clinically is really important. So for my GP colleagues, I'd suggest, unless you're concerned about a failed MTOP or you're concerned in terms of them being unwell, don't be too free-handed with ordering the quantitative beta HCGs. You'll often cause a lot of panic. So in this scenario, I'm reassured by that. Let's give Jenny an IUD if she needs it. But I think it's an important thing to remember that you don't go back to less than 5 or whatever it is, non-pregnant.
Yeah.
Typically.
And the lower it goes, the longer it takes to it approaches the x-axis and slows down as it approaches the x-axis. So 169 is a good 80% drop. If you were doing low sensitivity pregnancy testing, that goes negative at a beta HCG of 1,000. So it's not going to give you those worrisome, but I'm still pregnant results. So the learning from this, if we could go to the next slide, is that IUDs post MTOP, you don't need a beta HCG to be less than 5. That's probably one of the biggest learnings, because patients and GPs ask us about this. Do I need to have serial beta HCGs till it's less than 5? Or do I have to wait till I've had a proper period? It is acceptable to show if we've had the appropriate fall, if the patient is well. And I'm saying day 14 here, that's really conservative. I'm moving around to day 7, day 8 now, because I'm just a little bit more aware of the patterns, I think, and I've got more confident. If there's no sign of infection, bleeding screen was clear, she didn't need any antibiotics. And look, I've included this cheeky little slide here. Linda, what do you think is going on in this slide? So this is the scan that I did in the clinic just before I put the IUD in. What's the circular structure there?
Yeah. So my guess would be that's a bit of debris that's still in the uterus that you've got there.
So just to show everybody, this is the endometrial lining, and that is about as good as you can get after a miscarriage prior to the next menses. That's a really nice thin line there. That circular area is a corpus luteum. And that's why I mean it's a cheeky little scan. It's to remind you that she's 14 days post, sorry guys. She's 14 days post abortion, and she's ovulating again. So it's to emphasize that point, that leaving people till they've had a further period actually puts them at risk of having another unplanned unwanted pregnancy. So I thought that was a lovely scan showing that all systems were go again really, really soon. And there's always blood in the uterus, a little bit of blood in the uterus at the end of the surgical abortion when I insert the IUD. So we rub up the uterus, we use syntocinon, but there's always a little bit because the uterus relaxes again. And I will be quite happily inserting an IUD with a little bit of blood there, confident that there's not retained placental tissue. So a little bit of blood or debris around the IUD is okay. It's not going to cause endometritis. We're happy to take, oh, here's a question. Here's a question. I was just about to say we're happy to take questions. I'm sorry, it's too much for my brain to be reading conversations, but on the side when I'm presenting. But I see one here from TT Tang. When's the best time to start the OCP? And so there again, it's not really a best time, but I think the worst time to do it is to wait till there's another period. This patient could have it started now, but she could also have had it started the morning after that heavy bleed, which then became light. So with the history of probably passing it, she could start. What's the worst thing that could happen? She might have a little bit of retained products and that bleeding is masked a little bit by the pill. But if it's a significant amount, she's still going to bleed even if she's on estrogen and progesterone. I'm happy to take any other questions about this if anybody wants to type anything or put their hand up. Otherwise, we'll move on to Georgie.
Could I just say about the pill, Patty, as well with that question? I found in general practice that the 7-day mark after taking your misoprostol works quite well. So in a lot of pregnant people, I find the first 2 or 3 days, there is often still quite a lot of residual cramping and significantly heavy bleeding. And I agree with that point that Patty made, that I say to them, you could ovulate within 7 to 14 days after. And my advice centers around the first 5 days, you don't want anything inserted into the vagina. So no tampons, no menstrual cups, just use pads, nothing at all inserted, including no insertive intercourse. So I find that week mark usually works really well. And again, I like this clear timings, right? 9 p.m., 9 a.m., 1 week later. It's easy to remember. So if they're keen on the oral contraceptive and you screen them and it's safe for them, I find that 7-day mark is good and hopefully can coincide with the review by you, which while we have the sexual reproductive health item numbers for telehealth, can seriously be a 10-minute phone call. So they don't have to come all the way back to your clinic. You can just catch them on the phone as booked and remind them, you know, fill your pill script when you get your MS2 step. It's 1 week later now, start on your active tablet, do your quick start. So.
Great, thank you, yeah. And that week-long follow-up or leaving something for a week probably fits in with people's days of work as well, if they're only intermittently at their clinic. So this is Georgie, and Georgie is 24 years old. She's gravid 2 para-naught, and her last menstrual period from a regular menstrual tracker. She uses Flow, and so she's got that on her phone, and it was 5 weeks ago. She did a home urine pregnancy test. She's requesting an early medical abortion. She's had a previous one in Germany where she had no issues, and she actually also expresses a little bit of feeling slightly nonplussed that she has to go through quite so many steps in Australia compared to Germany, where she could get it at the chemist. Can we have the next one? Her experience was that it was really very simple. She was 7 to 8 weeks when she had it. She had minimal problems, and she would certainly choose it again. She's backpacking through Australia. So this is obviously pre-pandemic, this case. I should update it. So the beta HCG is 4,500, and you could order that. She could go to the lab on her way to the chemist, and then either takes the Miffy when she gets home or maybe the next morning, but 4,500 on day one. If you are going to be doing serial beta HCGs, you want the initial one to be as close to taking the Miffy as possible. Because if it's the week before, we all know the beta HCG is going to go up and then it has to come down. So it's harder for you to estimate what your 80% drop would have been. Implanon was inserted on the day of the Miffy. She gave a good history of passage of products of conception. She started to notice a bit of a malodor in the PV loss over 3 days when you contacted her 7 days later. And she's noticed that the cramping has returned in the last 24 hours. Could we have the next one? And so this is actually not uncommon. And the practice point here is to think about infections simultaneously in your screening while you're thinking about retained products. Sometimes we're so busy checking retained products, and maybe the patient had negative swabs pre-procedure, but there may be an anaerobic infection, or there may be a new infection of some sort, or it might be strep A that you never screened for in the first place. So always think about it simultaneously with your screening. So it's important to examine the patient and to take swabs. So again, if someone's reporting malodor, it's very difficult to manage that over telemedicine, but you could give broad spectrum antibiotics on spec while you're waiting. The British group, the low intervention British studies would have got the patient to self-collect and to send some swabs back into them. They all go out with a pack. Infection may present with prolonged bleeding or without too much in the way of fever or pain, but just ongoing bleeding after the 2-week mark or return of bleeding after the 2-week mark. Offensive PV loss is a very blunt instrument when you're asking people, is there any malodor? Because the blood itself can be malodorous to patients. We might make an assessment that that's not malodorous, but to a patient it's a new smell and they don't like it, and you probably would be overdiagnosing them now. So it's a clinical diagnosis based on the history rather than on the absolute exam findings. Next. So this is just a note on troublesome bleeding. This is the commonest hassle or presentation after medical abortion. It's common and it's usually not pathological. Clinical assessment is the most important. Consider expectant management or watchful inactivity for at least 2 weeks if the patient is stable. Always think about the role of hormonal contraception. And it's interesting to think about what's the role of implanon, famous for causing intermittent bleeding. It sounds like there is a bit of infection here possibly, but it could also be the role of implanon as she started it. The majority of retained products will self-correct. And I just wanted to make a bit of a comment between retained products and a failed medical abortion. A failed medical abortion refers to an ongoing pregnancy. Retained products is not a failed medical abortion. It's part of the process and it hasn't quite finished. An ongoing pregnancy is a failed medical abortion. The mifepristone has not intercepted the pregnancy. Ultrasound findings alone don't determine the management. And so I know this is the same scan, but you could easily have had the same scan for this patient. Again, shows us if she's ovulating, not particularly a great deal of debris or anything in the uterus. She might have presented with probe tenderness, which might lead you a little bit more towards thinking it was endometritis, or she may have a discharge and you're taking swabs. But sometimes expectant management or empirical treatment with antibiotics needs to be instituted on clinical grounds rather than the any particular diagnosis from the scan. I'll just go to the next one. Retained products, who to scan. So this is a patient who has got retained products. So this is the sac that has retained. So the sac no longer has a crown rump or embryo that you can see distinctly. It's actually also, with the eye of faith, you have to believe me because it's not great resolution here for you guys, but that's debris. It's lots of shadowing within the sac. The other thing to note is that the sac is collapsing. That's not a nice round sac like we would expect to see. And there's a decidual reaction around it, which has got some thickening and some bleeding. So this is a collapsing sac, but the sac has not come out. This woman actually reported, quite a bit of bleeding for the first 3 or 4 days. Some bleeding after the misoprostol, and then it just seemed to settle down. But she then went on to have ongoing cramps and PV loss after the 2-week mark. So if it's starting de novo after 2 weeks, or if it's carried on or got greater after 2 weeks, that's the sort of case that I would definitely scan. Or the PV loss increased in her case over the last few days. Or if the beta HCG had gone less than 85% at the 14-day mark. So I like Linda's rule of 9s, and then a week, and then 2 weeks, and then beyond 2 weeks. And the next one, and this is just to show you what retained products can look like on a scan. This is us doing a transvaginal scan and using arrows to show, it's not showing up particularly well, but this is usually whiter. If you go back to the previous scan that I showed you with that nice thin line, there isn't a nice thin line. This is the thin line coming from the cervix, and then you've got this, almost elliptical shape here. This is using color Doppler. So we can put color Doppler on, which shows the motion in the blood vessels going to and coming towards the probe, red being arterial and blue being venous. You can see there's a lot of vascularity there. If there wasn't a lot of vascularity there, I would still call it retained products, but the presence of ongoing vascularity in this size of retained products tells me it's probably not going to go away anytime soon. So that can be significant. And her beta HCG is 1850. Can we have the next one? So when to scan, this is my homily about when to scan. Chase the symptoms, not the numbers. Chase the symptoms, not the scan. So the length of bleeding is significant if it's greater than up to 2 or 3 weeks, if it waxes and wanes, if it's new onset. And then, of course, just to confuse us all, remember that menses may overlap with post-procedure bleeding. So sometimes people say it went away and then 2 weeks later it was really heavy again. And if you add it all up, that was probably day 29 that it started to bleed again. Talk about the type of bleeding the patient's having, passage of clots, how much she's soaking. The amount of pads people are soaking, I probably don't have to tell you all, is a much better way of asking rather than saying, was it a cupful, was it a teaspoon? Those are not measurements that make any sense with dealing with blood. It's more like, did it go through to your trousers or your underpants? And a cardiovascular assessment if they're in front of you, or you can even do that on telemedicine if they're dizzy on standing. Retained products of conception is actually a clinical diagnosis, not an ultrasound diagnosis. Because A, the ultrasound is often very non-specific. We've all had those scans that say there's a bit of clot or debris, consider retained products, correlate with the clinical picture. Ultrasound may help to determine management. As with the miscarriage, if the retained products are less than 50 millimeters, we might treat it expectantly, or think about a repeat dose of misoprostol. And some practitioners give an extra dose of misoprostol in fact, so that the patient can initiate it themselves. And again, if it's settling, don't intervene. And onward. So EMA and bleeding, just some practice points, because I've got my eye on the time here before question time. Normalize bleeding. It is normal to bleed. Talk about it as a process. We talked about the average being up to 14 weeks. Expectant management and review, and clear prompts to seek further review and referral. And there's quite a lot of interaction between groups that do a lot of early medical abortion. And many of you may be aware, but some of you won't be aware, that the government, when they funded our initiative, our Clinical Champion initiative, they also funded hubs. And sexual and reproductive hubs were to be areas based in community health where, you know, good numbers of long-acting reversible contraception were inserted by the practitioners, and good numbers of early medical abortion were being performed. And at the moment, we're up to 11 hubs, with more to be introduced. And when the hubs establish, they often interact really closely with the nearest referral hospital. For example, Peninsula Health makes great use of Frankston's early pregnancy assessment service, and have a really good relationship with them as to when to refer and how to refer, rather than just immediately going for a scan. And then we'll talk about pain before we wrap up, because pain's another issue. So this is not uncommon, and you might not actually hear about many of these, but patient has an MTOP last week through the local GP, but they're still experiencing pain and some bleeding. And they go to the chemist to request stronger pain relief. So I made this slide when I gave a talk to a group of pharmacists, because they were reporting to us that they were getting quite a lot of inquiries about how to manage pain post MTOP. So what would the next steps be? And not necessarily, now we're thinking about you not as a pharmacist, but you as a practitioner on the end of the phone, or as a nurse, practice nurse receiving this. The next history would be to try and determine what's causing the pain. Has there been a history of passing the products of conception? We need to assess their bleeding pattern, consider a diagnosis of retained products, and screen for infection, rather than just prescribe more pain relief. We recently had a patient who had quite a considerable amount of retained products of conception, and she also had a concurrent infection. And she was recommended by her GP when they referred her, when they assessed her, to come to our emergency department. But she'd also been given a very generous script for endo, and she felt too unwell to go into the hospital, so she took endo at home for 3 days and developed sepsis. So be aware of escalations of pain relief may need a timely referral for an escalation of diagnosis and management. Next one. Pain pointers. Pre-procedure, I'm banging on about this, but I can't bang on about it enough, because if the expectations are set clearly, it's much easier to manage the lived experience. Screen for suitability, and we've talked about that. Be proactive in the pain relief. Non-steroidals and larger doses and pre-dosing of non-steroidals. The research now, randomized control trials, are showing that that is much better than adding codeine. So we may still be adding codeine, but remember that, and remember an antiemetic. So getting the right medication in the right place prior to starting MISO is most appropriate. And that's anti-intuitive for most patients. They see it as the wrong thing to do to start medicine when you have no pain. So it's worth really going over that. And post-procedure, clear info regarding expectation of pain resolution and what to do if they have persistent pain. And I'm going to jump right back to something you said, Linda, about having a piece of paper that the patients can take with them if they have to present to emergency department. And one of the resources that we've got available online is like an A4 sheet. On one side, there is what to look out for the patient, what's abnormal, if you're soaking more than 2 pads over an hour, the pain persists if it's real, if you have signs of a fever, red flags. And on the other side, a bit of an introduction for emergency departments, because my other point to make is that not all emergency departments have staff that are familiar with the patterns of presentation with early medical abortion. So very quickly, if you're doing more than a couple a week, you will become more experienced than the junior resident in the emergency department at Benalla or Wang or something like that. So be aware of that. And a push for our free resources, because we don't want you all having to reinvent the wheel. When you go on to MS2 step, they do have open to doctors who are prescribers. They do have quite a lot of resources, patient information and consent forms, etc. But we also have other resources like that. And finally, let's talk about the one that we all kind of dread, really, the persistent pregnancy symptoms. So if a patient is still having pregnancy symptoms, they really need to be investigated. Timing is everything. We talk about having a timely follow-up and not having it too early so that we don't know how to interpret the beta HCG, or we're freaking the patient out because they're still bleeding. But we don't want it to leave it too long. And we need to talk to patients about the possibility sitting at around about 1 in 100 to 1 in 200 that it won't work. And the failure of mifepristone isn't a lot greater if you're approaching 9 weeks. It gets slightly greater after 10 to 13 weeks, but it's around about the same whether you're 5 weeks or 9 weeks. And obviously, in terms of where the patient would be seen and what her options are, the earlier that an ongoing pregnancy is diagnosed, her options are much more open. The date of her MIFI and MISO is always really important. Take a history of whether menses has returned or whether contraception was used and was masking it. There's often a history of some bleeding. And I still remember a patient who had had a previous MTOP and had experienced a standard amount of bleeding and had had a normal outcome, and had a similar amount of bleeding and had an ongoing pregnancy. And what alerted her to it was that her breasts were still very tender, even though she had ongoing bleeding. And what had happened was that there had been a bit of the misoprostol had caused a subchorionic hemorrhage, which was bleeding, but the mifepristone had failed and there was still an ongoing pregnancy. Beta HCG is important, but wait at least 14 days post-procedure before you measure them. And do remember this is a trick for young players, that beta HCG starts to decline again after 12 weeks. And the way you get the beta HCG report is problematic, because it will often say this result is consistent with a 5-week gestation or whatever. And in the abortion service, we unfortunately not uncommonly see patients over 20 weeks who've got a beta HCG that would fit the criteria for a 7-week pregnancy, and they're reassured falsely. So be aware of that. Think about when you did the procedure and don't be falsely reassured. It should be coming right down from what it was at the baseline. If it's static or increasing, arrange an ultrasound as soon as possible, and then think about where you would refer a failed medical abortion. Can you just show me the next slide, the final one? So the incidence is approximately 1 to 2%. It's slightly greater the further on the pregnancy gets. It's uncommon, but it does require screening for an index of suspicion. A beta HCG rising is much more likely than a history of products of conception. So if it's going up, there's something wrong. It doesn't go up and then come down. Not like with ectopics. More rarely is it a partial molar pregnancy. And so we've had one case like that where she had passed the products. There's still quite a lot of cystic retained products of conception, and it was indeed a molar pregnancy. Remember, beta-HCG starts to decline and have a clear referral pathway. And 1-800-MY-OPTIONS is where we've done a lot of work on this kind of presentation, and they will endeavour to really help this group of patients and talk to us about how we get them timely access to care. Because often they're choosing MTOP because it's not only more convenient, it's also cheaper, it's affordable for them. So we don't want them to have no options left because they can't afford a procedure. And so finally, before we open up for chat, what we can offer, as Kath said, is mentorship, support, a community of practice, local partnerships, and resource sharing. And we really invite you to either contact us or to take part in our quarterly network. There's also another community of practice which we work really closely with called OzCaps, which is a nationwide initiative and is gaining a great deal of momentum. And they have an interactive ask the expert a question section within their website. So it's AUSCAPPS, OzCaps, and they do quite a lot of research and qualitative publications through that, and a lot of advocacy work. So think about, and there's also MTOP Doctors Down Under for those of you who are afraid with social media. And I think I'll leave it there for questions and answers from me and Linda. Linda, did you have any other comments before we ask the group?
No, that was quite clear. I think just another plug for anyone who is on Facebook. The MTOP Doctors Down Under is very supportive. And often a very quick response as well, because we simply you'll have someone in Queensland or whatever who can answer very quickly where a pharmacist may be or what options are up there. So if anyone who's on Facebook all the time anyway, might be something to consider in addition to the other options.
Great. Thank you so much, Patty and Linda, for sharing not just the clinical information, but also your day-to-day experiences as well. We're going to do about a 20-minute Q&A session now, and I will open the floor if you have a question to put your hand up, and then we'll get you to introduce yourself, just sort of saying your role and where you're located. But before I do that, I think I might just start with some of the questions that came through on the chat during the presentation. Anything that we can't answer right now, we'll keep note of the questions and get a response to you in a follow-up email. But the first question I'll put to you comes from Heather. Just asking if there's any pharmacists in attendance today, because there's a question around whether or not the person picking up the MS two-step needs to speak directly to the pharmacist for direction and advice.
Thank you, Heather. That's a really good question. I'm not sure if there are any pharmacists. I'd love them to come in. This is something that will be in flux if the TGA make a decision about whether pharmacists have to be registered as well. At the moment, they have to go through a 20-minute registration, which requires them to have a conversation, not dissimilar to the way they're required to have a conversation with someone picking up the morning after pill. So the degree to which they rediscuss things and offer advice to the patient varies greatly. And so it's probably a really good practice point and worth repeating. Linda and I talked about it in much more detail previously about when you're setting up a service to develop those local relationships. To develop a relationship with the pharmacist so you know what they're going to say, they know what you're going to say. You might even share the same information leaflets together. But some clinics, the MS The Marie Stopes clinics, for example, their medication is on site, so they don't have to go through a pharmacist. We've got a good relationship with our pharmacist at the hospital now, so we know exactly what's being said to each group of patients. Do we have a pharmacist?
Yep, I'm a pharmacist.
Oh, identify yourself. This is exciting.
Emily Bitterscombe.
Did you have any comment to make about that, Emily?
I generally prefer the patient to be in the store, so I can just, clarify with them that they've been informed of everything, make sure they've got all the appropriate resources and whatnot. But I have provided to partners if I've had like a phone consult with the patient or if they were in the consult with the patient as well. But yeah, definitely try to prefer to speak to the patient directly.
And the next one.
Yep. All right. So the next question, thanks, Emily. The next question is from Jacques saying second dose misoprostol private script or via PBS. Prescribe MS two-step again and only take step 2.
So
you go.
Yep. So you can do a private script for the misoprostol. What I did when I moved into my local area and a few other chemists around, if you speak to your chemist and be very, very nice and let them know you'll be doing a few of these. A box of misoprostol, and the pharmacist can correct me, I think comes in 120 tablets. And if you've spoken with your pharmacist, they're happy to break it up. So I don't re-prescribe the MS two-step because I often will actually prescribe 6 to 8 tablets of misoprostol if I'm going to do repeat treatment with that. And chemist down where I am charges about $20 for that, for that set of the medication. So you can use it separately, but I think you've got to have spoken with the pharmacist. And if they're confident you'll be using it fairly regularly, they can order a whole box in. And dosing wise, I would normally get a patient to do 2 tablets initially, reminding everyone it's 4 tablets when you're doing the MS two-step protocol, and then monitor. So speaking with your patient, do 2 tablets initially, 4 to 6 hours later, if there hasn't been any PV bleeding, you might do another 2. And I usually talk about the extra tablets in case they, vomit it all up or something again. You've got that flexibility. So definitely private script, but it's not expensive. You're looking at a much less cost. And definitely talk to your pharmacist because they don't want to order a box of 120 tablets if you're never going to prescribe locally. Hopefully the pharmacist can back that up or correct my pricing and numbers around that.
Yeah, that's pretty perfect. Our pharmacy is across from the Royal Women's Hospital, so we do that all the time. So yeah, as long as you have a chat to them, I'm sure they'd be more than fine doing that.
All right. Our next question, I think Kath has already responded to. There was a question about where the sheet that Patty and Linda were referring to is available. And Kath, am I right in the link that you provided is where people can find that?
Yes, that's right. That's right. That's our webpage at Women's for resources and general information and various resources around early medical abortion.
All right, great, thank you. Our last question in the chat from Titi Tang. Did someone say that there was a special Medicare item number for sexual health consultations? Otherwise, are all visits and medical termination standard items?
So yes, there's the sexual and reproductive telehealth items. So for people who may not be aware, well, the GPs would be aware about how we got our items for longer consultations cancelled. If you are doing this work, there is telephone and video, telephone especially consults for the over 20 minute and over 40 minute that are still available. So really, really useful when you can't only use the under 6 minute one that we all know about. Now, the important thing with these item numbers as well is that there isn't a requirement for you to have an existing relationship with the patient. So if you have a patient who can't make it in and you haven't met them yet, I sometimes do my initial consults via video with these patients when I, from my clinic or when I work with the online service. Patients will get a rebate if you privately bill or if you choose to bulk bill. And another shout out for the pregnancy directive counselling 4001 in person. There are also telehealth item numbers for that. So I'm quite happy to send my copy of those item numbers out as a resource so the GPs know that this is actually still supported via telehealth. And we are, a lot of us who work in this space are actually negotiating that these item numbers become permanent. So telehealth exploded during the pandemic, and then as GPs would know, a lot of it's been taken away. But this is one of those extra special items where we've got access, no existing relationship. And I think they're current at the moment. They're tossing up July versus December, but we're doing a lot of advocacy and places like OzCaps as well if you get involved. We're trying to make sure we make these permanent so people have access, and we're confident that's going to happen. It's an interesting space, but definitely worth having those item numbers on hand. If you,
I couldn't agree more, Linda, and there is a lot of advocacy, and it's one of the repeated items of advocacy in the submissions to the Senate inquiry, that this could be a game changer. In the same way as floating early medical abortion on the PBS was an absolute game changer. It took it out of the hospitals, didn't it? Mm. This could now make it even more viable for community health and for private practitioners in general practice.
All right, one more question's popped up in the chat asking if there's any data available on ectopics occurring with very early medical abortion without ultrasound.
Yeah, there is. And you can access these very big cohort studies through the MJA and the New England Journal of Medicine on very early medical abortion. And I said before, it was very reassuring in terms of safety and efficacy. So one of the key outcomes was obviously the incidence of ectopics. Now, when I said they had big numbers, we're talking 20,000 in each arm. So huge numbers, and the British one, 50,000. And they did not have an increase in ectopics in the patients who didn't receive a scan but had the protocolized risk assessment. Mm. What they did discover was that the proportion having really early medical abortion when they moved to this low touch or low intervention technique greatly increased. So prior to them having this methodology, would have been maybe about 30% of women were having early medical abortion in Britain under 7 weeks. That figure rose to 60% with this technique that was introduced in the time of the pandemic. What we do know about ectopic pregnancies through our work in early pregnancy assessment services is that we are more and more likely to treat early ectopics expectantly. So beta HCGs less than 1,000 early on, quite a number of those will resolve. We've discovered more through early scanning, but are we actually over-treating some of our ectopics? Is probably what's happening. It's important to have the good follow-up and make sure that because the maximum time for a rupture of an ectopic is around about 8 weeks. And beta HCGs, once they go over 5,000, much more likely to rupture. So it's really important at that 2-week mark, if you're doing if you're doing an early medical abortion at 5 to 6 weeks, that you would then be following them up around when they would have been 7 weeks.
Thank you. Were there any questions from anyone in the audience? You can add to the chat or take yourself off mute and ask.
I'd be really interested to hear if there was anyone who had started prescribing. We were just talking about this before we ran the webinar. Anyone who started prescribing wanted to provide feedback. You know, has it been an off-putting experience? Often when we talk to people who've been doing early medical abortion for a year or two, one of the most common things they say is that, look, it hasn't been as big a deal as I thought it was going to be. Yeah, we managed it. We had to put a lot of effort in at the beginning to get the relationships right with the ultrasound and the chemist, had to make sure all of the reception staff were on board and they knew how to schedule an appointment, and so that there was good access. But once we got all our ducks in a row, it wasn't as bad as I thought it was going to be. That's the most common thing I hear, but it'd be interesting if we had somebody who wanted to share their experience. Don't be shy.
While we wait for anyone else to comment, I just thought with Jacques' questions around ectopics with the very early medical abortion, I thought I'd share in my mind what helped settle my anxieties around it. Because I thought, oh, what am I doing now when I've got someone, you know, it's possibly 4 weeks and nothing on scan, was firstly to remind yourself that ectopics are rare. Okay, so you're dealing with something that's rare anyway in your pregnant patients. And then in reality as well, I mean, I'd say to my patients, look, if you have an ectopic and you get to 8 weeks and it ruptures, what you're doing with the medication isn't necessarily that much different. I know that sort of sounds backwards thinking, but I think of it as I'm not harming my patient necessarily if I've safety netted them well and given them good advice, because this was possibly an eventuality anyway, if you think about it that way. That helps me to sort of calm down and think I'm not actually, you know, causing significant harm to my patient if they're safe and can get to hospital, etc. Whereas I can make a massive difference if I give them early access, let them get on with their life. So you kind of got to do your risk-benefit analysis. And, you know, someone in your room who's desperate to get on with it, doesn't want a partner to know, doesn't want their mother to know. You've got to pick your patients, obviously, like we were chatting about, but try not to be too anxious around that. And as Patty says, the studies show that it's safe. And it just happens so rarely that it's not something that should dissuade you for patients appropriate, I think.
Any last minute questions that people would like to ask, be big or small?
Comment here. Thank you for sharing. It's from Michelle. Thank you for sharing your knowledge and expertise. I will share this with my team. And look, that's really one of our key messages, is share it. And think about a community of practice. Come to these events, and even if you're just contemplating, or maybe even if you're pre-contemplative, that you could have a discussion with others in your practice. And if there were one or another person in your practice, you would and you shared your results with each other, you'd very quickly get a body of experience within your practice, rather than, you know, maybe doing 1 or 2 every now and again. Oh, here's Heather Dowd. Thank you, Heather. Lovely comment from our dear colleague, Heather Dowd. I work within one of the hubs. It works well. The nurses I work with are great. Thumbs up. Thank you, Heather. And that team and task sharing is a really big way of primary care deliveringness. We know that at the moment, Medicare is stacked against us. If there's funding for practice nurses, or it's a community health system where there is another funding stream of a salaried nurse, it makes it much easier if the tasks are shared. And Heather is also saying that she used to notify her medical defense if the client couldn't be followed up, but she doesn't know anymore. And I think 100% follow-up has never been achieved. I suspect that it's much higher in primary care than it is in a hospital clinic, because nobody ever wants to come back to our clinic. And I say that without bitterness. Why would you want to come back when you're normal and wait in a big clinic? And there's many more incidental meetings. I know one GP who says, you know, if they've got children, I'm so much more likely to see them again for something and then be able to follow up with them. And so that used to be one of the things that people, Heather, often talk to us about. There's like the follow-up's driving me crazy. I'm spending hours trying to follow the patients up. Our recommendation around that, and I wonder about yours, Linda, would be to make 2 documented attempts. And then, you know, my philosophy is that the patient has agency. They had agency to come and seek this abortion, and they are making a decision of some sort, particularly when you said you were going to contact them if they're not picking up.
Yeah, absolutely. I agree with that, Patty. I do make those attempts. Using telehealth items, I find makes that a bit easier if it may be hard to get to in clinic. And I found as well with time, reminding yourself that this is safe. You're using safe medication. The chances of follow-up not happening because someone's very unwell are low. And for most of the things that happen, if it has been quite dramatic, most people have turned up at a hospital, and it may just be that they're done. They don't want to talk about this, think about this anymore. So I agree, respecting that choice, making sure you document it to be safe, but it does happen not uncommonly. But yeah, the telehealth makes it easier. A quick phone call, check in there well. They may just go, yeah, all good, no dramas, and that's enough, I find. We don't need to labour it with them.
Thank you. All right, we can still pop a couple of questions in the chat that we'll make sure get addressed in follow-up emails, but we just have a very short 5-question poll that will be anonymous, that we're just really hoping people can stay on and complete, because it will inform future training that we do, the content of sessions such as this one, and also just to get a sense of what kind of support practitioners are needing. So I'm just going to share my screen now, and if you could, if you've got your mobile handy, to go to menti.com and put in the code that Tilly's popped into the chat. It's 6515204. So if you go to menti.com on your phone, and that will bring up the poll, and I'll share my screen so that we can sort of see a live response as people respond to this. Give people a few more moments for this question. Okay, we're moving on to the next question. Are you a provider of early medical abortion? We have a few that are currently providing, a few people who are supporting GPs to provide, also a few who aren't providing, and then a few more who aren't currently but plan to become a provider, which is good to see. Right, move on to the next one. Have you become a provider since attending the first session? And for those who did attend the first session and have or haven't become providers, and if you feel comfortable to, it'd be great if you could pop into the chat or share your thoughts about, you know, what some barriers are to becoming providers or what helped you to become a provider. Okay. And question 4, if you are not a provider, please share why. And so these responses will come up anonymously. And we have a comment about the financial viability of early medical abortion in the general practice. It also seems like there's a few people who aren't GPs but support GPs. Okay. Follow-up may be difficult, not having quick access to clinical advice from experienced providers if all does not go smoothly. But yes, AusCaps will be a great resource to help with that. Awesome. If you've got one more comment to add in here, I'll just give one more second and then I'll move on to the next question. So what would support you to provide early medical abortion? We have a few where it's not applicable to be a provider, but something that would support is prompt access to clinical advice, and the communities of practice are very important. More engagement from GPs. Yep, we've also got some people who are already providers. Okay, one more comment on that was probably done resources and looking for resources where this can be discussed if any doubts, and being allocated enough time. Yep. Great. All right, we're going to move on to our last question. and well, it's not really a question, but if you would like direct support from the Clinical Champion Project with Patty and Kath, please pop your email into the chat, and then we can make sure that you're followed up with. And I know as well that the PHN will be sending through a follow-up email, and we can share the resources and the slides. All right, thank you for sticking on to the end and answering the evaluation questions. I'll pass over to Tilly to close.
Thanks, Sarah, and thank you to all of our presenters tonight. Linda, Kath and Patty, your wisdom and advice is always enlightening and really practical. Also, thank you to all the participants for joining us this evening for a long 2-hour session and for your participation in our evaluation and Q&A session. Up on the screen is a QR code for the PHN evaluation. Please take the time to complete this as well. And also a very big thanks on behalf of Sarah and I to the PHN for supporting us in delivering this session. We really look forward to working with you again in the future. Thank you, and I hope everyone has a lovely evening.